Hi, my name is Seb Crosswell, one of the ST8 registrars on the rotation. I'm going to present to you the long-term clinical and radiological outcomes of the Copeland surface replacement with an average follow-up of 12 years. This project was performed at the Great Western Hospital in Swindon. So a bit of background. So this gentleman on the right is Steve Copeland. He was a consultant orthopaedic surgeon based in Reading, and he helped design with Zimmer Biomet this Copeland resurfacing. And the aims were really to preserve bone stock and also preserve the normal biomechanics of the shoulder. The indications when it was first released was similar to that of total shoulder arthroplasty today, osteoarthritis, rheumatoid arthritis. They even put them in some younger patients with AVN and post-traumatic OA. The prosthesis underwent some development over the years. It went from the Mark 1 to the Mark 3, and the one we look at in our project the Mark 3. The Mark 1 was just had a pure polyglenoid component and a metal humeral component. They then added back a metal back glenoid, and then they added a peg with an HA coat in the Mark 3, and people then started to put it in a hemiarthroplasty fashion rather than a total shoulder arthroplasty as it was originally designed. So the total shoulder arthroplasty is still the gold standard for osteoarthritis, that's reverse or anatomical. The issues with this is there's a significant degree of polyethylene wear, which then leads on to glenoid loosening and osteolysis. This is reported as high as 80% at 10 years. This leads to a quite demanding revision surgery in about 15% of these cases. The modern hemiarthroplasty might be able to provide the comparable clinical results to total shoulder with less risk of glenoid component failure. However, there's only small studies, especially looking at the Copeland, and it's generally done by the designer institutes. So the aim with our study was to look at the outcomes of our Copelands, looking at revision, evidence of glenoid erosion, follow-up and PROMS data, with an average of 12-year follow-up with a maximum of 15 years. We looked at 97 Copeland shoulder resurfacing performed by 4 surgeons between 2006 and 2012. The indications again were similar as that originally described. Our primary outcomes were revision surgery, so that was decision to revise despite medically being unfit or proceeding with revision. And we looked at the PROMS, and the PROMS that we chose were the Oxford Shoulder Score, the SF12 and the FAS. Secondary measures, we looked at demographics, indications of surgery, mortality, complications. We looked at the pre-op radiographs, and we classified them with the Walsh classification. We looked at the follow-up radiographs, and we used the Rasproli classification. So we looked at all our patients. Our median age was 72. 73% of those were female. A majority had intact cuffs, and this was assessed at the time of operation. And using that Walsh classification and the pre-operative radiographs, the majority had concave pattern of wear. There was a few B1s, which was a more posterior kind of pattern of wear. Majority of these were put in between 2006 and 2008, and 80% of those were put in for just shoulder osteoarthritis. So we're looking at our PROMS data. We had a mean Oxford Shoulder Score of 31.3, and you can see that PROMS tended to decrease with years after surgery, which kind of makes sense. The VAS score, we had a pain at mean of 3 and a satisfaction of 7.7, which is again fairly reasonable. We had a physical score of 14 and a mental score of 16. Again, fairly reasonable mean scores. The revisions, which we're really interested in, so at 5 years we had a 99% survivorship, at 10 years 93.5, at 15 years 73%. These survivorship data excluded the lost follow-ups and the mortality. So we calculated the estimated median time to revision was 15.2 years, which again for a surfing is not bad at all. We lost 57 patients who died during the follow-up period, so about 6% of our patients, but we did record their kind of preoperative and indications for surgery. Follow-up radiographs, so 13 came back for follow-up. It was difficult with COVID bringing these patients back. And I think the main point here is using this Rasproli classification. The main thing that we saw was there was a slight oversizing of the prosthesis, and 100% of the patients had some form of glenoid erosion. We didn't see the osteolysis or the bone mass, you just saw the erosion, which is often similar to the pattern of their osteoarthritic wear. Complications, we had no surgical site infections, no prosthetic joint infections, and no dislocations. 26 of complications reported, 73% of those were pain. And looking at through some of the revisions for indication, the reasons for indication, majority were pain, and then the second most common was glenoid erosion. And I think that actually some of the pain ones had glenoid erosions, which are causing their pain. So in conclusion, the revision rates are still reasonable. 15 years, that's 73%. The complications remain low with good PROMS data. So is there an argument? It's a small operation, it's bone preserving, it's just glenoid erosion, no osteolysis, and it's easier to revise? Or is there an indication for the younger AVN or post-traumatic patient? However, 50% of these had revisions, but the average time to revision about 8 years. And the other question is there a role in the elderly intact cuff patient or who have high medical comorbidities? Thank you for listening.